Confidence Doc podcast is brought to you by My Evergreen Med Spa. Located in Houston in the Woodlands, My Evergreen Med Spa brings to you the latest aesthetic treatments in the most luxurious environment. Remember, My Evergreen Med Spa, it's me time elevated. Welcome to the Confidence Doc podcast. I'm Dr. Rednam, and I'm a board-certified plastic surgeon in Houston, Texas. And today I have a very special guest, Dr. Andy Elkwood. Welcome to the show.
Thank you. Thanks for having me.
So, Dr. Elkwood, you are a double-board plastic surgeon, and you currently practice in, I'm going to say Red Bank, New Jersey, correct?
Correct.
And you have a very specialized area of plastic surgery. You largely work with nerve reconstruction. And I want to get into what that means, but I want to talk a little bit about why did you get into plastic surgery?
Well, I got into plastic surgery in medical school. We had a rotation. We had these elective rotations within our general surgery rotation that you can take a couple of weeks with a physician and, in a subspecialty. And I had the privilege of rotating with this fellow named Jim Hain, Dr. Jim Hain, who has since passed away, unfortunately. And he had a reconstructive practice, and it was just inspirational. And I said, this is really the coolest stuff. And it was since then that I pursued it. So even when I applied for general surgery and got my general surgery boards, it was always with an eye towards doing plastic surgery, and particularly reconstructive surgery.
And it's interesting, I've interviewed a lot of plastic surgeons, and majority, it's that 2-week rotation that, like, hey, I had an elective and I did this. That was like, okay, that changed my whole trajectory.
Well, because I think all facets of medicine, when you get into the upper echelons of it, it's all really interesting. It's all really thought-provoking. When you're on the cutting edge, it's all really cool. So a lot of it is if you have the right mentor that made their specialty that much cooler than all the others. And you're a sponge, as you know, when you're a medical student. It's like everything turns you on. And if you just have the right chemistry and it clicks for you, then I think that happens to a lot of us that get into your field,
And I know for you, there's so many facets to plastic surgery, but I know for you, you really fell in love with the reconstructive side of plastic surgery. And your specialty is largely with nerve reconstruction. Can you explain to our listeners what it exactly that means? What do you do with nerve reconstruction?
Well, I think I'm sure you have a sophisticated set of listeners, but not everyone understands what plastic surgery really is. And I think a lot of even physicians don't really get it. So, plastic, as you know, means to change. And there are two major components to plastic surgery, right? Cosmetic surgery, which means to take something normal and improve upon it. It's normal to have an aging face, small breast, big nose, whatever it might be. And then reconstructive means taking something abnormal, whether it be form or function, and making it normal again. So abnormal form, a woman that had a mastectomy or a baby with a hair lip. Abnormal function is something like someone with a paralyzed arm. What people often don't realize, as you know, microsurgery is a subspecialty of reconstructive surgery. When an arm is severed, it's the plastic surgeons they call to put the arm back on. And in doing so, obviously, you have to fix the bone and the blood vessels and the muscles and the tendons and the nerves. And there are a handful of us around the country, maybe around the world, that really got turned on by fixing the nerves. And that's what my calling card, my practice for years and years was a general plastic surgery practice with this concentration in nerves. And it's since then really been limited to the nerve surgery. And I love to operate on nerves of the face, nerves of the arm or upper extremity, nerves of the pelvis. The pelvis, probably the most unique calling card for me. And taking people with paralysis or chronic pain from a nerve origin and fixing them. And, there's a lot of overlap with other specialties, whether it be neurosurgery and orthopedics and so on and so forth. But I think the plastic surgeons really have a unique approach to these problems. So I hope that answered your question.
That does. And I know that chronic pain is an area that gets overlooked a lot. Sometimes people throw their hands up. We don't know what to do. But that's something that you've actually pushed into, especially you were mentioning before with pelvic, right? Can you explain a little bit? Because you're one of the few people in the world that take care of this very, very specific issue.
Right. So nerves send multiple signals in two directions, out to the fingertips of the toes and back to the brain. And those signals can be feeling, they can be motion, they can be pain. And depending what part of the nerve is injured, you'll either get paralysis or numbness or pain. And the other thing about the brain is if the brain gets a disorganized signal, let's say from the fingertips, and it's kind of a rudimentary signal, static, let's say, the brain interprets that as pain. So many problems with chronic pain, chronic pain can emanate from a lot of things. Pain can be a good thing, right? If you're hurting your knee and it tells you to stop before you hurt yourself, then, pain is a good thing. But if a nerve is injured, that can be one of the causes of pain. It's sending an improper pain signal back to the brain. And just like people think about something, let's say like carpal tunnel in their wrist, where the nerve is compressed and you can get numbness, weakness, or pain, you can get the same thing in your pelvis. And I think as plastic surgeons, we are uniquely qualified to operate on the nerves of the pelvis. Many of us are general surgeons first, so we're comfortable in the pelvis. And those of us that are reconstructive surgeons that enjoy operating on nerves, you're kind of uniquely qualified if you have both of those backgrounds. Neurosurgeons are great with nerves, but they're not always so happy to operate in the pelvis. Whereas general surgeons, urologists, gynecologists are often very happy to operate in the pelvis, but are not happy to operate on nerves. And when you start looking, there are hundreds of thousands of patients that have nerve problems within the pelvis. And the natural extrapolation from operating on those nerves for pain and so on is to operate for function. There are many patients that have what we call failed back surgery, that they had a disc, they had the disc repaired or whatever it is, had a fusion of their back, and they still have pain, weakness, or numbness. Sometimes that's from the nerves and not just from the disc level. So we see a lot of patients like that. So it's really interesting stuff. And, these patients don't have a lot of places to turn.
How do these patients find you? Because like you said, there's a lot of physicians who aren't really aware of probably even how to diagnose this. So how do they find you for you to be able to evaluate them and fix these issues?
Well, some of them have their primary care or whichever treating doctor, let's say a urologist or a gynecologist, is savvy enough to know that, hey, this may be coming from a nerve issue. And will either know of myself, and it's really a team, it's not fair to say me, it's knows of the team, and will refer patients directly. Some of those doctors may do some research and find us, but most of the patients that find us really find us on their own. And that's one of the wonders of the internet these days, right? There's all kinds of self-help groups and chat groups. And, we do publish quite a bit, and that helps patients find you. We try and lecture as much as we can. But I think the most frustrating thing is really getting the word out that some of these patients, we see patients that have been suffering for decades and then can find us later on. And it's kind of they're happy they found you, but they also are unhappy that they've wasted a lot of their lives without solutions.
In this case of these things where, like you said, you're really specialized in some of these areas, are these things that typically insurance is covering or they're considering experimental? Is that something that you're able to comment on?
Well, it's a mixture. There are some insurance companies that believe it to be experimental. There are some insurance companies, frankly, that I think hide behind calling things experimental. There are other insurance companies that are very accepting of it, and it all depends. And just like we need to educate the medical community and need to educate patients, we need to educate insurance companies. And it's not always mean-spirited on their part. They're just not aware of it, and their medical directors may not be aware of it. So we do a lot of lecturing to insurance companies and a lot of outreach to them. And sometimes, frankly, it's frustrating, but we'll send them articles and so on and so forth. And we have a whole team of medical professionals that can outreach to the insurance companies if there's a denial and so on, and try and set things straight. In the end, I think we do pretty well in making the care available to people. We don't give up easily. And sometimes we have to push harder than others. But we usually find a way to get it done for the patients.
Well, and I think it's very helpful that you have the evidence within your publishing and you're able to support, no, these aren't experimental, and we have real proof of the improvements that patients have with this.
Correct. And I think what goes hand in hand of being an ethical physician, if you're doing things that can help patients that are not yet widely understood or widely accepted or widely known about, I think you kind of have an ethical duty also to try and push the envelope and make it available for patients. So.
Absolutely. And speaking of kind of, pushing the envelope and doing bigger, better things, you are the one that really came up and spearheaded creating the Advanced Reconstructive Surgery Alliance, also known as ARSA. Can you explain a little bit for both the physicians and patients who are listening, what does that mean? What was the purpose of creating this?
So, for people that aren't aware, there's two kind of basic camps in medicine. It's not absolute at all. Kind of the academic camp, where typically you are employed by a hospital or by a medical school or something like that, and you do a lot of teaching, and that enables you to do some more advanced cases and be more innovative and so on and so forth, and put you in that environment. And then the other basic camp is private practice, where not exclusively, but for the most part, most clinicians are doing kind of the bread and butter things, don't have the platform or wherewithal to really be pushing the envelope and advancing the field. And that's great. That's wonderful. I mean, patients need care, and very little of what we do is innovative, right? Most is things that we know. And like I would say, you don't want to be the interesting patient. You'd rather not be interesting, But nonetheless, for the most part, the mindset of most physicians is in one camp or the other. And what we said in designing ARSA is, why can't we do both? Why can't we be academically minded surgeons in private practice? And in fact, we have a lot of advantages that academia may not have. We have a certain nimbleness. We don't have the same level of bureaucracy and hierarchy. And what ARSA is really finding like-minded surgeons throughout the country and bringing them together. And the tough part of this privademic model, being academically minded in private practice, you don't have a lot of infrastructure behind you. If you want to write a paper, you're the one typing in Word, right? You're the one going through the charts and collecting data. Whereas in a university, you've got people around you, you have fellows, you have medical students and all that can help. When it comes to getting the word out, if you're a solo practitioner, it's very hard to have an online presence. It's hard to do. You're busy taking care of patients every day. But if you share these resources with other like-minded surgeons, it's very doable. And the analogy I always use is a very mundane one. But if you only mow your lawn one day a week, doesn't it make sense to share a lawnmower with your neighbor so that you don't have to, you can both have the better lawnmower? And if you're really smart, you'll share it with 6 other neighbors. And that's kind of what ARSA does. So it allows us to push the envelope, to be academically minded. And in fact, as I said, I think it gives us a certain advantage because you don't have that bureaucracy. You're not pigeonholed, which some people will often complain that a university environment will do for them. It took a lot of work to get us where we are, but I think all the surgeons in ARSA really feel the benefit of that platform. And I think it translates to patient care. We're able to outreach and care for patients and get them results that they couldn't find elsewhere because we have the backing of ARSA behind us and those resources.
And how many surgeons now fall under ARSA's umbrella?
We're over 100 docs at this point across the country.
And obviously, for those who know, my practice is part of ARSA as well. So we're very lucky to be part of this organization because just like Dr. Elkwood said, we not only do we have the resources, but we can help educate each other. We can help lift each other up, which means that all of us can provide better patient care, which you just don't see elsewhere. You don't get to see that kind of collegiality in general in the private world. While we often share, it's not at the same level. So we get the best of both worlds.
Right. And the educational program that we have, the cross-educating, you were there at our last annual seminar. We have our 2-day scientific session where usually first day is didactics, right? Lectures, and we kind of cross-lecture to each other and in a very informal setting, which I think is much more, what's the word? Much more better.
Much more better.
And then the second day, not to get grisly about it, we had a cadaver day with 7 cadavers, where for surgeons, that's the way we learn and that's the way we teach each other. And we cross-educated. How many people were in the room? 70 surgeons, maybe or so.
A lot.
On different procedures and, different approaches to things. So, to me, that is the kind of sine qua non. That's the gold standard of what ARSA can really deliver. And I don't know of any academic institution that has regular programs like that. And so on.
And, for our non-physician listeners like this, it's important. This is the type of thing you want your surgeons doing. You want us to be continually educating ourselves, learning more, and getting better because, like I said, that allows us to provide the best care for you and for your families.
And frankly, some of the learning goes, the most valuable learning occurs at lunchtime or break times when people can just talk casually and say, I have a patient with this or that, or what do you think? How would you handle this? It's kind of the curbside stuff that's also really valuable that you get at ARSA as well.
So what are you excited for in the future? Maybe not just with ARSA, but also with your specific area of plastic surgery. What do you see on the horizon that you think is going to help continue to push the envelope?
I think what's going to help continue to push the envelope is outreach to the patients. And as our patient population and number of successful patients grow, it's like you're probably too young to remember the old Breck shampoo commercial. They told 2 friends and they told 2 friends and they told 2 friends. And that's how you reach the patient community that's out there and people that you can help. So that's really exciting. And as we build our team of surgeons, that increases. So for a while in our practice, I was the only person doing, let's say, the nerve surgery of the pelvis. Now we have a whole team. And you can reach that many more patients and educate that many more doctors and so on. So I think that's super exciting. I think we have so many procedures in development through ARSA to hopefully help patients and tackling new problems and new pathology with some of the techniques that we use. I think that's really exciting. And we're really attracting attention to the like-minded surgeons that are out there. And there's more of us. And the funny thing is, surgeon, as you well know, surgeons would typically choose private practice or academics, and they're usually a little remorseful in either choice that they make because they're leaving out the other thing. But for a lot of those that chose the private practice camp, I think we've encouraged them to put their toe back in academia, because the support is there to provide good care. So we speak to a lot of docs that even just did solely cosmetic surgery because it was harder for them to do reconstructive surgery on any sort of scale. And now we've encouraged them to do a lot of reconstruction again. So I think that's a lot of fun. It's very encouraging. And ultimately, I think good for patients.
I agree. And I think you're right. I really remember when I graduated, you really felt the split. You have to pick this or this. And if you picked one, you're giving up the other. You're giving up certain procedures and things that you enjoy doing because that's just how it was. And I like that rather than splitting, we're bringing things back together again. Because our specialty is all about everything. We don't have to choose.
And that exactly. And that's why I kind of started towards the path of ARSA. When I left academia, left training, so on and so forth, I'm like, why do I have to not do this case? I'm good at it. I can help someone. And frankly, some of these patients aren't going to get helped elsewhere. And you say, well, the downside is I don't have the support staff to do this, or the referring docs to do this a joint case. And you start looking for other joint docs. And let's say we're doing a head and neck case. We need a head and neck surgeon as well as a reconstructive surgeon. Well, you find someone in the community that has the same bend that you do. And you say, we're doing it. We're good at this. We can help people. The only reason we're not doing it is because we don't have the platform behind us, but we're going to build that platform. And then you start sharing the platform with others. And the next thing you know, you wake up in the morning, you have ARSA. And that's really what it was.
I love that. I love that. Well, thank you so much for being on the show and for sharing all this. If somebody is very interested in learning more about ARSA or the specific types of procedures that anyone in the network provides, how would they find that?
So 2 websites. There's an ARSA website itself, arsahealth.com. And that's more about the administrative side of ARSA. And then advancedreconstruction.com is the kind of the patient's portal.
And that would be where they'd be able to find more information about you specifically and what procedures you perform as well?
Exactly. And that's a place to start. And, if things look right, they can call. We've got a very large call center, both with medical professionals. We have a physician. We have a couple of physician assistants, a nurse practitioner, as well as many lay people. So they can start getting questions answered, or at least pointed in the right direction of maybe getting help.
Well, awesome. Well, thank you so much again for being on the show. And I really, for our listeners, I'm very excited about kind of this return back to, it sounds like back to the basics of plastic surgery, where we can be not just a cosmetic or reconstructive surgeon, but both together, which is what we started off as in plastic surgery. So thank you all for listening to the Confidence Doc podcast. And as always, I hope you learned something new.